In healthcare, there's often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. Today, we're bringing back, this will be our second time, welcoming Kirby Williams to the Melanin Initiative. She's a psychiatric mental health nurse practitioner from Richmond, Virginia. She came with us the first time talking to us about and breaking down bipolar disorders 1 and 2. She did a really beautiful job. We'll put the link in the description box so you can go back and watch that. As I mentioned before, we are reaching a global audience, but have a special place. Me in particular, I'm from the DMV. This show is my love letter to my hometown. And so anytime that we can bring resources to you in terms of resources you can reach out to or actual people, we want to make sure that we do that. That's a special intention that we have so that our part of the country can be known for more than just politics. Although we do encourage our peers to be involved in policy, because that is how you get in sustainable change. All the things you're complaining about at the bedside, at the point of care, it can be fixed through policy. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison. You can tell I'm very passionate about a lot of things. And I am one of your co-hosts here at the Melanin Initiative, along with Alicia and Geraldine, who send their love in their absence. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it to manage your health and advocate for others. It's our hope that by watching on YouTube, LinkedIn, Facebook, Instagram, or listening on your favorite podcast app, that you'll be empowered to ask questions, educate on how you can manage your health and advocate for others, and confident to navigate the healthcare system. We have two missions here. The first one is health literacy, breaking things down into information you can understand. Our second is to elevate the expertise of nurses, which is what we're going to do here today with Kirby when we talk about vicarious trauma in providers, as well as bring awareness to all the career options that are available to this in this huge industry that we call healthcare. And then inform our peers how they can leverage their expertise outside of direct patient care. There's so many skills that we develop and so many ways that we can leverage them in and outside of this industry. If you haven't already, this is your chance to subscribe so you can be notified every time we release a new episode. Give us a thumbs up, leave a comment or two. That's how the algorithm knows this information is important. When you interact with our videos and our content, it shows that it's of importance so that when people like you look for information like this, we'll show up higher in that search result. This show is for educational purposes only. The opinions that we express here are not our opinions. They're our opinions alone. They're not a representation of any of our affiliations. If you think you might be experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. If you're having a mental health emergency, you can call 988 or text 741-741. We're delighted to bring back and have the honor of introducing you to a trailblazer in psychiatric mental health, a mentor, an educator, an entrepreneur whose work is shaping the future of psychiatric mental health nurse practitioners. Since earning her psychiatric training from the prestigious University of Virginia, Kirby has been making waves in the mental health field for over a decade. Starting her career in mental health practice in 2012, she quickly expanded her reach, stepping into academia the next year, where she educated and inspired both undergraduate and graduate nursing students for nearly a decade. In 2019, she saw the critical need and founded the Black Psychiatric Mental Health Nurse Practitioner Collective of Virginia, a community dedicated to empowering Black psychiatric nurse practitioners and addressing their unique challenges. She didn't stop there. She is a visionary behind Beacon Behavioral Health and Consulting, her private practice where she provides psychiatric services to adults in Virginia. Her passion for mentorship and education led her to establish the PMHNP Source LLC, an innovative professional development company offering you digital products and a community support to guide those of you who are new psychiatric mental health NPs in navigating your careers. Everything from preparing for the interview, negotiating your contract, and making that transition, which can be a steep hill to climb. From groundbreaking initiatives to creating platforms for professional growth, Kirby Williams is a force to be reckoned with in mental health advocacy and education. Join me in welcoming the inspiring and unstoppable Kirby P. Williams.
Woo! Oh, thank you, thank you, thank you. Lovely, lovely intro. I appreciate it.
It's fun. Shout out to Shannon Sharp for showing us the importance of giving people their flowers where they can still smell them.
Yes.
In the last episode, we played our new game, 5 questions in 5 minutes. Now, I just gave your introduction, but if you could just tell our audience what inspired you to go into mental health and what keeps you there after all this time.
Yeah, great question. So, what got me really interested in it is working on trauma units in the hospital as a floor nurse and realizing the gaps for patients who were experiencing very significant traumas from car accidents to losing limbs to losing persons that they loved because of very traumatic incidents. And I thought about, is there a way to kind of bring my knowledge and experience together and combine it with mental health to really look at trauma, to really look at PTSD. And I was so excited to, go and get my degree and to do that. And what has kept me here? I think what keeps me here are the patients. They really do keep me here, keep me present, keep me grounded, because I think they are so brave. I think they have gone through some very grand and great significant experiences, and they continue to push forward even when it is hard. And even the pushing forward is of even letting me into their lives. That is pushing forward, and that is hard to do. And so they keep me here.
Yeah, and so you've been so kind to come on and talk to us about vicarious trauma and providers. And so the whole idea this came behind, this whole talk of burnout. It's, you hear it everywhere.
Yeah.
I'm burnt out from hearing it. And so, I went to my good friend, ChatGPT, and I asked him to a list of conditions that parallel burnout, right? So we can have evolve the conversation. And so, yeah, we're going to get into it with you. And we're going to
Yeah.
speak to our peers, right? Because we spend so much of our time treating the public, and we are also the public, and we need that attention just as much as anyone else. And in fact, we're more prone to putting ourselves last on that list and, just taking this information and giving it out instead of taking it in and meditating on it like we need to. So really delighted to be able to do this for our colleagues. We love our patients, of course. That's why we're in this work. That's why we continue to show up every day. But we also, empathize and relate to our providers who are also making extreme sacrifices when it comes to their own health and the time they spend with their family and get to explore other interests. And so we're happy to dedicate this episode and to do more of these where we focus on what I'm calling provider-centered care,
Oh,
provider-centered practice,
practice.
right? Because we learned so much about patient-centered care, which is super important. And I don't think we need to throw it out. We can still be there. But in that same circle, I think we can invite this conversation of provider-centered practice. And what does that look like? That looks like me having time to go to my own doctor's appointment. I'm standing on a walking pad right now, right? Because I still need to get my steps in and not, say, well, I can either do this or I can do that, right? I'm able to do both. And so you're going to hear me talk more about that. And so, it just really, and the longer I stay in this profession and continue to advance my career, I just notice how much it demands of me. And with all this information that we know about how to care for ourselves, we need to be able to apply it.
Yeah.
So what is vicarious trauma?
Yeah, so vicarious trauma is they may call it a phenomenon, but it's an experience where, because we're speaking about providers, where providers or healthcare professionals will have emotional and psychological distress. And it is a result of being exposed to hearing traumatic incidents from their patients, typically, or from the patient's maybe loved one, or witnessing the patient experiencing trauma or great distress.
And who's at risk for this?
I would say when it comes to who is at risk for this are gonna be, I actually did look this up because I said I want to see like who would be the greatest, who's at the highest on the list. And there's actually two specialties, so to speak, that are the highest on the list. One is mental health providers, and the other were those healthcare professionals who work in the emergency departments, emergency rooms. Those were the two, but really it would be any healthcare professional who is doing direct patient care in some capacity, even if it is part-time, even if it is not a full-time job, but if you're doing direct patient care in some capacity, you are at risk for experiencing vicarious trauma.
And why do you think those two in particular were at the top of the list?
Yeah, I know. I thought I was like, oh man. Well, I kind of knew because I'm in mental health. I kind of knew that one. But I would say, so mental health providers and professionals, because we do ask patients a lot about their lives and experiences beyond their symptoms. And that means asking and going into detail, if they feel comfortable doing so, about very maybe traumatic experiences they have had with abuse, maybe traumatic experiences they've had with or like car accidents or something such as that. We also, when we think about Hurricane Katrina and people being displaced in other spaces, and then they had to, what they were seeing, mental health professionals, they were talking about those experiences of what they saw, what happened to them, who they lost, and how that was for them to move to another place. And so mental health professionals really do hear a bulk of that. And we do ask about it too. So it's not like, oh, we hear it and we haven't asked. We have asked, and people do, if they feel comfortable, present it to us. And so I think that is why. And then the other thing about the emergency room or emergency departments are because that person's, when they're coming to an emergency department, it's because typically there is a medical emergency, or there is some great distress that physically or mentally as well, that I have to come into this setting. And so they are the first kind of line that persons are going to speak to about the distress. Maybe they're having a medical emergency of some sort. And so then we actually witness that as an emergency department professional. You're actually witnessing the person have that emergency. For some persons, that might mean we are witnessing someone and then that person passes away. And so that can be very, traumatic. And that experience, depending on also probably the trauma level of the emergency department, how many traumatic incidents that you might see or be exposed to.
Yeah, and I think that those in particular, and just all of us in this space, also because we have to put our experience to the side, like immediately, and move on and do the next task, right?
Yeah. Definitely.
In one room, you're someone just died. In another room, someone's about to give birth. Someone just got a bad diagnosis. I mean, it's all over the place, and you're all over the place with that.
Right. With all those, with all those emotions that come along, with that, or that could come along with that.
Yeah, and then we have the impact of our peers. Maybe they don't feel like we did a good enough job in the last 12 hours since they left. We're feeling that. We're feeling all the things we have to document on the computer. We're getting those performance evals on top of all of that, right? The lack of sleep because you're going home to raise your family and teach, do their homework and maintain whatever you've built at home. You're in school. You're preparing to graduate.
Man.
Yeah, I think our students might be one of the most vulnerable because they really don't have the tools yet.
Right. Yeah. Definitely. That's very, very true.
And so let's talk about some of the myths. One of them being like we should be immune to trauma, right? Or just part of the job.
Yeah, that last one. This is just that one there. That one that touched me in my heart. That one about this is a part of the job. So. And maybe a person doesn't say this words, toughen up, but the way in which they say it to you about like, oh, that's part of the job can feel very dismissive. It can feel like, well, you wanted to be a nurse so bad, or whatever the healthcare professional is so bad. This is what comes with the territory. So, get with it or get to step in, or whichever the case. But it can feel like that. It can feel very dismissive like that when someone might say that. And I have seen that happen to persons who are newer to the healthcare professional field, and they might express their feeling, whether it's to a leader, their leader in healthcare, wherever the department is, or to someone who is more experienced in that area where they're working, and they kind of get that bit of dismissiveness of like, this is what we're supposed to be doing. This is our job. This is a part of the job, kind of a thing.
Yeah. So what advice would you have for the response for that person? Should they try to redirect that communication or just go seek help?
Yeah, I would say in those situations where I think this is where's Oprah or somebody, when someone shows you who they are, believe them. So if a person is, when you mention something to someone and they are very dismissive, they might not be, they're giving you information that they are not the correct person to support you. They're giving you the information. They didn't say it out loud, but they said it out loud, that they're not the correct person to support you. And so I would say that that would mean, maybe talking to, and it might even help if, especially if you're a newer professional, talk to other newer professionals, because, you might be in the same kind of playing field, so to speak, or someone who is like, you just started in the emergency room and someone else started in the emergency room 3 months before you might could find more empathy and understanding with that person who's newer to the role or to the department that you're in.
Yeah, I think that also speaks to the generations, right? We know healthcare is intergenerational. We have people all ages. And even they might have more age, but still less experience, right? They might have just entered the profession. And so, yeah, that peer support that you get could really be anywhere.
Yeah.
Because someone could be doing this for a long time. And when they trained and came in, whatever you get in the beginning, that's kind of what continues, right? It's a little bit hard to read, even though you do all the education and you see all the webinars and the modules, you still are agreeing with that train of thought. And so you may be of a generation where we did just suck it up and move on. So again, to your point, and it could be kind of like that, like abuse, right? That's what I got, so that's what I'm giving.
Right. Yeah.
They could be just as a victim, if you will, as you are. But they just, it hasn't been diagnosed or identified.
Yeah. And maybe when they brought it up, if they did, when they were newer, they got that experience. So they're like, well, this is how it rolls here.
And then I just want to talk a little bit about how this is a normal reaction and response in this work that we do, right? It's not a sign of weakness or that you're not cut out for the job.
Right. Yes. I've started to say we are in, no matter what kind of field or profession, healthcare profession you're in, specifically, whatever discipline, we are humans helping humans. And so what that means is that we are persons with emotions. We are persons who have feelings, who have needs, who have responsibilities, persons who, have experience where something comes up and it can throw off our whole day, because we are human. We are persons who can make mistakes because, again, we are human.
And so when you talk about diagnosis and we all self-diagnose, before we make that appointment. What could be wrong with me? How long is this appointment going to take? Who should I see? Right?
Yes.
And so we might experience emotional exhaustion, cynicism, decreased empathy from others, even ourselves. Right? Even I might have a conversation with myself and say, girl, you did all this to get here. Suck it up. Don't complain. Just do what you got to do to get where you want to be. Right. So it could be internal, intrusive thoughts, and then physically fatigued and headaches.
And just like feeling pain. Some people will have like even chronic kind of pain feelings that are not related to necessarily like a physical injury, so to speak. But when it, the mind body connection is something that's very real. And so it can even be seen as that as well, as far as physical types of symptoms that could come up.
And so when you're doing that diagnosis, what does that look like? You have another screening tool?
So for this, I have heard of a screening tool, but I will say I have not seen it in practice. And so I'm not as well versed on, I can't even think of the name at this very moment, but not as well versed on it because I haven't seen it as much. But it's called something to do with secondary trauma, which sometimes people will call vicarious trauma, secondary trauma. And so, what I try to do is, especially when a person comes in, usually for an appointment, they're coming in because something has distressed them so much that they're here, decided to make the appointment, are here in the appointment now. And so typically what they're coming in with, especially seeing myself, is for those emotional kind of complaints or emotional symptoms that have come up for them. Just being really irritable, feeling very sad, lack of empathy, feeling apathetic, maybe even about their career and things like that. And so they're coming in for that. And so for me, what I have to try to look at is say, okay, let me look at frequency, duration, and timing, trying to figure out when this occurred. So if this is, let's say, an adult that I am working with, maybe they're in their 40s and they never had an experience feeling like this before. In their 20s and 30s, they cannot remember a time where they felt depressed or having an episode of just being really irritable for a long period of time, days, weeks, or months. Then I'm thinking to myself, so where did this kind of start? And so figuring out with them, having them help me to kind of paint that picture of when these things started and maybe what started to happen around the time. And sometimes what that'll look like in an appointment is that a person might express, a very stressful situation that they saw, or multiple stressful situations or distressful situations that they saw in their work, and how maybe they carried that with them, or they thought about that patient for days and days on end, or weeks and weeks on end. They kept checking, checking to make sure the patient was okay, or, asking their colleagues, about the patient, because they just became kind of maybe consumed or very, very worried about a patient or about a certain situation. And so those are the things that kind of typically come up. And what I want to kind of look at is like, when did this start? Were there any surrounding events that happen around the time, to just be very, to really get to the root of kind of, what this came from and what it is.
When you have like healthcare professionals coming to you and maybe like the first visit or two, do you find anything different about them as opposed to the public? Like, are they coming in, are they using their EAP benefits? Are they getting referrals by, other people in the field?
That's a good question. So I would say typically when I am working with other healthcare professionals, they're actually not using their EAP. And I would say a person did actually tell me sometimes they don't, but they were worried about their work finding out about or knowing that they were seeking mental health support or help in a way. And so they did not want it to be any way related, connected to their work. By going through EAP, they'd rather, still using the insurance, but just going a different way, a different route. I also sometimes will notice with healthcare professionals that, especially those who are also providers and may have learned about diagnoses and treatments and things like that, that they come in and say, "Oh, well, I know that, I know that, I know that," and not in a mean way. I think they've always, like anybody would, already have tried to figure it out themselves, already have tried to understand it for themselves. And sometimes I've noticed that even though they have come for help, they're still a little bit guarded about what they say or how much they say. They might still say something, but like how much they say.
Hi, I'm Alicia from the Melanin Initiative podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
Yeah, I would imagine, because I haven't done it yet, but I've been pretty public on my other platforms about that's where I'm going next, the next provider I'm adding to my list. I would imagine it's either, and I don't know how I'm going to be. God pray for the person who I have. I think I'm either going to be an over-explainer or, real hold back a little bit.
Yeah.
And to be honest, I'm going to be real honest, because I am on social media, I kind of don't want them to know that because if they have homework and I don't do the homework, I don't want them watching me online and saying, "Hey, look, I told you to do this. You're still not doing that."
Yeah.
Now I meet so many of you and it's like, I could get a great referral, but then they're going to know me and I want to be able to show up and not have to wear those hats.
Right. Yeah.
You know, so that's me, the professional coming. And a lot of times I don't want my provider to know that
Right.
I just want to be treated like a
like a patient or
when they do start talking, I start, it's tough.
Yeah. No, it definitely can be. It's hard to be, I think, for us as healthcare professionals, it is hard to be the patient because not that we are more in control, so to speak, but that when it's the other way around when we are in the healthcare professional seat. We're not the one who is looking for assistance, looking for help. And we're the ones who we hope, having some of the answers to give the public about what's going on. But when we're in the other seat and we maybe don't have the answers, that can feel a little awkward and weird.
Yeah. So what are some treatment options that you might recommend?
Yeah. So when it comes to vicarious trauma, it's really going to depend also with kind of the person's functional level. Have they gotten to the point that they are, hopefully not, but so irritable that they've cussed out a patient, for example? That's a different kind of, okay, maybe you need to take some time away from work because this is greatly affecting your ability to do your job in a compassionate way. If you are someone who, yes, you've been more irritable, but you've still been able to do the work, you've still been able to dig deep, and provide that empathy and compassionate care. And then I would look at, okay, well, are we at a space where it would be helpful for you to find supportive options, such as being in therapy, working with a therapist on a regular basis to really figure out some solutions to how you are coping with the experiences? Because I can't say that the experiences will go away. If we work in healthcare, it's not like, oh, I can still work in healthcare and, not see ever anything traumatic or distressing. No, you may can work in maybe a different department that might have a less of that potential possibility, but there's still going to be your patients who might express different things to you about their lives, even if you're not the mental health professional. Because when patients have a moment to speak with someone, sometimes they speak it out. Yeah, it's coming out. It's coming out. So looking at that is really working with a therapist to find those, what are going to be, or can there be coping skills to help you manage this in a very meaningful and intentional way. And can you start to work with someone who will give you some tools and some skills that you can start practicing on a very regular basis and utilizing in your life? So those are kind of the treatment options that we think about. Just someone needs to, have some time away from work, which can still be very beneficial, especially if it's really impacting your work and your ability to be professional, empathetic, and a compassionate provider. Or is it, okay, yes, you can still work, but you're going to still need that continued support. In both ways, you're going to need the continued therapy support in it, whether you are taking a pause from work or, still working and working with a therapist.
So I want to get some clarification for myself. We have our in-house trauma therapist, Kelsey Wilson, also based in Virginia. You guys can go see her in Reston at the Google building. She's been on several episodes. We did intergenerational trauma, anxiety, depression, how to navigate the holidays with your family, EMDR, and cognitive processing. Therapy. I can never remember if it's therapy or theory. I know she's going to kill me.
Okay, that's okay.
So she's taught us that there are different therapists, and I hear you'll specifically say physician and PPA, and then you also said therapist. So when you say therapist, are you grouping everyone, or are you delineating?
That's a very good question. So I am, sometimes they can be grouped together. So when I'm thinking about a therapist, I'm thinking of a mental health professional who does engage in doing therapy regularly with patients. Now, what that means, psychiatrists can do this. Some don't for various different reasons, but they are trained to do it. Nurse practitioners, psychiatric mental health nurse practitioners can do therapy, and some of them do it, within the scope of what they learn, what they know, what training they've gone through. And so it just really depends if those persons are doing it. And so, but most people who are therapists, we're thinking more of LCSW, licensed clinical social workers. We're thinking of LPCs, licensed professional counselors, and we're thinking of like PsyDs, a doctoral psychologist, so a psychologist as well. So typically those are going to be the three types of healthcare professionals who do therapy on a regular basis. But like I said, also know that there are some psychiatrists and psych NPs who do therapy as well, and who have training in that and do continued, education and training in that space as well.
And when you say therapy, you're talking about talk therapy.
Talk therapy, yes. Talking about talk therapy specifically, especially when it comes to vicarious trauma. I know you spoke about someone who talked about EMDR, which is a trauma focused therapy. That's eye movement.
Desensitization.
Yeah, I was like, desensitization, reprocessing. And that is used for trauma as well, but that's used more for a very direct and specific traumatic event. Whereas vicarious trauma can be more of that kind of a slow burn, so to speak, because it can be kind of continuous. And so it hasn't been found to be as helpful in that space. So this would be more of that talk therapy that I'm speaking to specifically.
Thank you. And since you mentioned it, the difference between psychiatrists and psychologists.
Yes. So psychiatrist is a medical doctor who has trained in psychiatry, and they typically are doing do psychiatric care by prescribing medications as well as doing evaluations to diagnose mental health conditions. They have the ability, yes, to do therapy. Some choose to, some choose not to. A psychologist is someone who does therapy and makes psychiatric diagnoses as well. So they are not persons who do any kind of prescribing of medications. And so if you are seeing a psychologist who you've been seeing for talk therapy, you've been working on things together, and for one reason of another, they say, it might be a good idea to consider medication for whatever the reasons that may be, then they're going to be referring you to a psychiatrist or psychiatric nurse practitioner who has the ability and credentials to do that.
And so then you will be seeing two people?
So in some cases, that would look like seeing two people, a person who is doing your primary, therapy, talk therapy, maybe once a week, every 2 weeks, maybe once a month, kind of depending where you are in your journey. And then someone who is focused mainly, not all, but mainly on prescribing a medication for your symptoms, condition, or maybe even it might even be an underlying condition. Because sometimes when you're in talk therapy, other things come out. Yes, you came from vicarious trauma, but actually we have found that you have an underlying also depressive disorder, let's say. And so that, should be treated so that you are optimally working in your career by having your depression treated. So in those cases, you would be seeing two persons, but for what we call psychiatric medication management, you're not typically seeing that person as often as the therapist. It could be that you're seeing the person who is providing the medication and the prescription once a month, every 3 months, maybe even every 4 months, whereas that talk therapist, you might be seeing weekly or biweekly.
Okay, so psychiatric medication management, that's kind of a big difference too, right?
Yeah.
And so with Kelsey, I think her visits are about 50 to 55 minutes. So since they're not seeing you as often, are those visits as long?
So they are shorter because they are focused on medication, especially when someone does have a therapist that they're seeing and having these 50 to 55-minute visits once a week or every other week. The appointments that then we're having with the person is going to be focused on, okay, how are things going with the medication as far as side effects overall, how are their symptoms, but mostly in relation to the medication, since they are continuing to work with that therapist on coping skills, on different ways to manage the symptoms of vicarious trauma.
And EAP covers all of this?
So EAP, I have seen typically EAP cover therapy, so with a therapist, and for a limited amount of sessions. That may be, I've seen eight sessions, 10 sessions, 12 sessions. I typically have not seen more than 12 sessions. I have not typically seen EAP, and correct me in the comments. I have not typically seen EAP, that's fine, cover psychiatric medication management. That's not what I've typically seen. But if there are places where that does happen, definitely, like I said, correct me in the comments. But I typically have seen it for therapists and therapy.
But the other insurance is covering it.
Like if you're not using EAP.
Yeah.
Yeah, if you're using just like your commercial insurance that you have, correct. It is usually something that is covered, and if covered, even if you're seeing both of those types of providers, because we're doing different, even though we're still working on your mental health, we're doing two different kinds of services. There's a psychiatric medication management service that's different than the therapy service.
And you mentioned that at the top of the show that you see a lot of people aren't using it because they don't want that no
Connection.
part. I would be curious, and if there's anyone listening or watching who's familiar with the data, because as an employer, and it's like, look, I'm offering this extra benefit for my employees, but I've heard from my other friends nobody ever uses it, so I'm really not. It doesn't cost me. I'd be really curious I'd be curious about that data.
Yeah. No, that would be good. And then I would say the other, we'll just say challenge with EAP is that though it will cover, let's say 12 sessions with a therapist, not every therapist takes EAP.
Oh.
And I believe, correct me if I'm wrong in the comments, but I believe there are some, reimbursement type, issues and challenges there. So not everyone chooses to take that. So the list of EAP providers might be shorter than your list of, providers who take commercial insurance.
Okay, thank you. And so we've identified what vicarious trauma is. We've identified who's at risk and that it's kind of unavoidable if you stay in the work. So let's talk about coping mechanisms.
Yeah. So I know I said I wasn't going to use this word about self-care, right? Because it's overused. But what I want to say is that having regular and consistent ways of pouring back into you, and that has to be whatever that means to you. Because for me, it might mean trying a new restaurant, but for you, that's not your vibe, and that's okay. And so you might even have to do some reflection and thinking about that. If you haven't engaged in those type of activities regularly or haven't been able to because you have been very stressed out, overwhelmed with work, in school, like you mentioned, taking care of your family, maybe you haven't engaged in those activities in a while. And so it might be helpful to reflect upon that for some time and also do some exploration and field tripping about figuring out what are things that really help to pour back into you. But doing something like that regularly can be very helpful. For you. And this doesn't mean just when I have a bad day, but at the end of every shift, you have a kind of a routine that you do. And so for me, I like to do the routine of using Insight Timer. It's an app and they have affirmations, speeches, and they have calming music, but they have all different kinds of options that you can utilize. And they have some that are just meditations that are 2-3 minutes. So it doesn't take a lot of time. You could just go to your car, do your 2-3 minute meditation, and then drive home. And so that's your moment of woosah and separation from work to, home life. Doing something like that can be helpful. Also, what can be helpful is sometimes it's going to look like if you kind of review kind of your workplace and your work environment is putting in some more regular boundaries with work to set up a structure for whether that's overwork or set up a structure for maybe you having less direct patient care kind of time. Are you in a space where you can do this part-time and, have some other activities that you do for your financial compensation elsewhere to kind of provide that balance for you? Are you in a situation where you could talk to your boss about taking on some different responsibilities and bringing down your direct patient care, like FTEs, so to speak? Is that a possibility in your work environment? Maybe it is, maybe it's not. But those are two big things I think can be very helpful. And then setting boundaries. Also, I talked about workplace boundaries, but also setting boundaries with yourself. I've had to set boundaries with myself about stopping, not checking email messages after a certain time or patient messages after a certain time, and then making sure that patients know, because I want to be explicit and honest with them and transparent with them, that they know when they might expect to hear from me. So it's not an expectation where they might be messaging me 3 times in 3 days. If I have something in there that says, we'll return messages in 48 to 72 hours, okay, they know that information and I won't come back to a overwhelmed, kind of patient message box.
Yes, very well put.
Yes.
And so when we talk about for our colleagues, for ourselves as employers, for our employees, how can we foster a more supportive work environment?
Yeah, I think, and I don't know if people, I think I've seen this maybe one time, but having persons who are assigned to be the peer support on a unit or in a department. And the reason I say that is I used the example earlier about like maybe you expressing yourself of, having distress in your role. And then a person was like, is dismissive to it. And maybe they're dismissive because it's just not their ministry. And that's okay. But if you assign people where that is their ministry really is supporting other peers, then that person now knows where they can go. They know I can, I don't have to worry about just telling anybody my business because maybe that, I'm going to go to this person and they're not going to be dismissive to me. And maybe that those persons are, armed, so to speak, with resources and things like that to also provide. So I think having something like that can be helpful because, people want to have a place to go and they don't want to have to ask around and maybe tell other people their business. And so if they know like this is the person who they're going to be supportive, they know about the resources, I'll just talk to that person and I know I won't be dismissed. I do believe that can be helpful.
Yeah, and I think if that person takes on that role, they also need to be someone of integrity, right? I don't need to hear my business.
Right. Yeah. That's true. Someone, yes. Needs to be vetted. Yes. Needs to be a vetted position. And if it's something where a unit or department, wants that person who is let's call it the peer support person of the unit of that department to do more specific types of responsibilities, then I do think that unit, organization, that department should make sure to, yes, one, compensate the person and or decrease some of their time in other areas so they can have more time and capacity for that. Because if we don't, then we're going to put that person in this situation and we're not going to have no peer support because now they have the person who, needs more assistance because they don't have the time and capacity to give to the peers who need support.
And what about all of our friends out here who are entrepreneurs and they're at the kind of the beginning of their business, and so they're a one-person show. So what can they do to, or maybe they have an assistant, right? Still
Right.
a small team, right? Does that advice translate?
Yeah. So no, because they have a small team, or it might just be themselves. So it quite wouldn't. So for those persons, what I would say is that they do have to then cultivate a team, obviously outside of their business, because they're just maybe one person, cultivate a team or cultivate, or find or locate one. Even if you don't have to cultivate, you might have to locate one. And there is one, and I don't know if it still offers free membership, but there's it's for nurses, but it might be for all healthcare professionals, but it's Operation Happy Nurse. And they're on LinkedIn. I know they're on LinkedIn, and they have an online support community for nurses and tools for addressing burnout, stress management, other wellness topics. I know they have like webinars and maybe they don't call it support groups, but some type of support network. And so that might be something that then a person who's an entrepreneur would have to seek out and make sure they secure. And I would say to secure that early. It doesn't mean you have to use it all the time, but at least know where it is so that when it is time, how to tap into it. Even if you're not feeling like I'm at a place where I really, need to, at least knowing of that.
Yeah, and I think that's a good point to mention because we talk about the risk factors, right? And if you're going to keep doing the work, you're going to keep being exposed. And so even, I don't know if it was through doing this work or some other things, but I came to realize, because I think in the beginning, the talk about mental health and having a provider or adding that to your group of people you see regularly was like to be reactive instead of proactive, right? So I think they should be on the team, just like you should have an eye doctor, just like you should have a dentist. So when I ask you, do you have a primary care provider, I'm including them in that conversation. And especially because we're in this line of work, and if you add on being an entrepreneur, you need somewhere where you can go and talk, where it's just about you 100%. Because even I notice I have people who love me, right? I have people who love me in my life. But even when I talk to them about my concerns, I'm still thinking about how they're going to respond. I'm still thinking about the way they receive information. So even still, I'm still in that seat, right? And I need to go somewhere where I don't need to do any of that.
Yeah.
That's a realization that, I recognize in myself.
Yes. Yeah. No, I think that is so very helpful to have. And even I have a therapist as well. And I've had one for quite some time.
I heard someone say if your therapist doesn't have a therapist, run.
Yes. That it, boom, you got it. That is, and I did that proactively to have that, and it is helpful as an entrepreneur and also as a healthcare provider to have a space where you can, whether it is venting, whether you can process hard days, process just tough emotions that you might be happening or that you might have seen or experienced, is having a space to do that in, because sometimes when you don't have that space to do that, it gets pent up. It gets pent up here. And I think that relates to sometimes that irritability that we see, sometimes that apathy and that lack of empathy that we see, because it's all just sitting here. And so you're just like, I got nothing else because I got all this stuff just sitting on me because I haven't been able to process it or express it to anyone in a meaningful and intentional way.
Yeah, we know in particular, both our physicians and our nurses at the bedsides, a lot of times they're the breadwinner in the family. Everyone sees all of us from before we even get into that school. We're hustling to get in the program. Then we're hustling in the program. Then we're the new provider hustling to make the transition. Then we're hustling to start the business, right? So people see us as high performers. They see us as problem solvers. So even when we come to them, even when they listen and give us their full attention, but I know you got this. You're going to be fine. You get it. You do everything.
Yeah, right. You made it through all those hard things. You're fine. You're fine.
Yeah. And I just had a telehealth appointment with my derm PA, and she's like, I can do hard things, and I was like, yes, we can do hard.
We can,
but still, right?
Yeah.
And I think for our peers who are just entering the profession, all of the people we mentor, I think it's really important because we tell them they need to have a resume, they need a network, they need to have a LinkedIn page. Well, we want you to know today you need to also have a mental health provider. And I think if you're going to be a provider, I think you should also have an assistant. I realize that as an entrepreneur, how having someone else just alleviate some of the burden in life can help you be present for that marriage that you just created, be present for those children that you just birthed, answer emails, send out gifts, call, get the groceries, like those little things people aren't telling people, and it adds on to everything that you're trying to do. And if you spent the last decade hustling,
right,
you don't get out of that mindset.
Yeah. And then when you're not like hustling or sometimes not in that energy, then you almost feel like I'm missing something. I must not be doing something.
And it can mess with your identity.
Definitely.
I think in our brainstorming, you mentioned the compassion fatigue workbook. Was that you?
I don't think so.
Well, we'll put that in the
hey, put it in there.
The resource. Yeah, that was another one of the topics that parallels burnout. And one that caught my attention. At the moment, I have decision fatigue, right? As being a provider, right? Because I'm making all these decisions at work. I'm coming home making all these decisions here. I'm starting a business, making a lot of decisions there.
Yeah.
The smallest thing, my family's they're gonna laugh. Even if you ask me to choose a restaurant, I'm gonna break down. I don't have even the energy to do that, right? They've gone on some monologues in the last couple of months about picking a restaurant.
Just choose something.
Anything, because I'm just over. I'm fatigued.
I'm fatigued. I got you. Yes, you're fatigued.
So let's do our 3 TMI takeaways for our audience today when it comes to vicarious trauma for providers.
Yeah, so the takeaways I really think are kind of reflect on how you are not performing at work, but how you are engaging at your work or in your work. Pay attention to that. If you are noticing that you are not feeling as compassionate for patients who you are working with and partnering with, if you start to feel very irritable by every patient, every decision, every phone call, those types of things, be mindful of that. Just take some real hard note about that, because this may be lining up to be that you are experiencing vicarious trauma. Also, when it comes to vicarious trauma, I want you to really know that and you said it best, Dr. Madison, you said it best, making sure that you have persons on your team who are just for you.
Yeah.
Yes, you mentioned assistant, but also, having that mental health professional, having that support group or some kind of supportive network that you can tap into regularly, because that's going to be very, very helpful. And then I hate the word self-care, but make sure you have regular activities that you can tap into that refill your cup, that rejuvenate you. And these do not have to be big or expensive activities, and they do not have to be long. This could be, like I mentioned, after every shift, listening to a small meditation. Insight timer is free 99. So
Even that is a real thing.
yes, that is a real thing. So you utilize something like that, and just having that separation from work time to home time, or to off work time, or whatever you want to call it.
Hmm. And then I was going to say something. What's the last thing you just said? This happens every episode. What's the last?
No,
What's the last thing you said?
that's okay. Having that break between, having some transition time between work time and non-work time.
Yeah, and then when people are, scheduling out their life to make space for that, right? Make
Mm-hmm.
space for yourself.
Mm-hmm.
Oh, that's what it was. So it can be tough because you invest so much. You lived out your parents' dream by applying to this program. You got
Mm-hmm.
accepted into this Ivy League school, UVA, right? And you invested hundreds of thousands of dollars.
Mm-hmm.
You sacrificed, you missed weddings, you missed funerals, you missed very important things, right? All these people trained you, they mentored you, they poured into you. You
Mm-hmm.
have spent your whole adulthood doing this one thing. And
Yeah.
now you're like, maybe I don't want to do this anymore. And it can be hard to realize that for yourself.
Yeah.
And then to admit it. There's actually a physician on right now on YouTube. He is a neurosurgeon,
Mm-hmm.
but he stepped down from surgery, and his channel has blown up.
Wow.
And yeah, can you just imagine just like, the thought process, even when he had to renew, it's like for one of the licensures he has to continue to perform surgery in order to maintain it. And he
Yeah.
had to make the tough decision,
Mm.
like he's not going to do that. And just think about all the hours he put in.
Yeah.
And it can be, it's a tough decision, but there's support out here. There
Mm-hmm.
is life after patient care. That's the
Yeah.
biggest message I want to point out, is there are other ways you can leverage your expertise, right?
Mm-hmm.
You get in these
Mm-hmm.
communities and you can find out other ways that you can do that and still have a very fulfilling career. I think for me, my biggest message every day is telling each other, when we go to school, that's patient care school. It is only a small percentage of what we can actually do. We have so many skill sets. When you see Apple, Google, Microsoft entering this field, they recognize the value that we can bring. And because we live in a bubble, we go to home, we go to work, we're in a bubble of healthcare. I'm talking to you, I'm talking to the patient. I think everybody knows this information. So I don't even appreciate what I know.
Mm-hmm. Yeah. Yeah.
And because we're a nurse platform, when it comes to the patient experience, from the time they enter the industry to discharge, subacute rehab, long-term care, nursing home, home health, hospice, death, the nurse is the central person through that entire process,
Yes.
up leadership, including, right?
Mm-hmm.
Nurses just don't recognize that because it's not in school, and school cannot teach you everything.
Right.
They
So
just
true.
can't do that. You have to take initiative and
Mm-hmm.
come out here and be exposed to other information.
Mm-hmm.
Seek out mentors like our friend Kirby here, who offers that. She's doing that because she recognizes it's necessary. You don't have to struggle in silence, suffer in silence.
Mm-hmm.
All the things you work so hard for, that big dream you have, you can live that life out.
Mm-hmm. Yeah. Yeah. No, I just love everything you just said. And also love what you said about not struggling in silence, not having to, have that struggle as you transition to this new role. And I would say, what I tell people about that is that, there is struggle that happens, but struggle can be a terrible environment for learning. So if you are in a space of I'm feeling like I'm a constant struggle, no support out there, it's going to be really hard for you to learn and take things in and grow. Even natural, it's going to be hard for you to do that. But if you tap into support, it allows you, yes, I still have some struggle moments, but I still got this support here so I can actually reflect on what I'm learning, learn more, have capacity for growth in different ways.
Yeah. So how can our peers connect with you?
Yeah, if you're interested in connecting with me, you can find me on LinkedIn. You can find me at Kirby Williams. You can also find me On Insta, I am at your PMH&P mentor, and you can also find me and information about me and the services that I provide for new psychiatric nurse practitioners at the PMHandPsource.com.
And this show airs into 2025. So can they also refer their patients to you?
Yes, in 2025, you can refer your patients to me. You can reach me. You can connect with me as a professional through LinkedIn, and I will give you my telephone information, and we can discuss through there to make sure the person is a appropriate fit for the services that I provide. And even if you are not sure, or even if I find like, oh, I don't take that insurance, still call me, still reach out to me, because I know a lot of other colleagues in the area, and I am so grateful to make sure to give the referral to them if it's something that it's outside of my specialty.
Speaking of specialty, is there anything in particular you specialize in?
Yeah, I would say treatment-resistant depression, PTSD, anxiety disorders, bipolar disorder, and psychotic disorders. Those are my specialties where most of my experience lies, and what I really feel very passionate about.
Mm. And do you do telehealth and in person?
So actually, I know I'm a unicorn probably, but I do all all in person.
Oh, okay.
All in person, because I found that is for me, and we always have to do stuff that you said. What did you say? Provider-centered care?
Practice.
Practice. Yeah, sorry, provider-centered practice. So for me, and thinking about provider-centered practice, I really work well with people in person. I have personally a hard time working in such a intimate way with people, so to speak, through telehealth. That's really hard. And I really feel that it's so powerful for me to examine people fully, in person, to really get sometimes even a better picture, and to notice little nuances too. When you see someone in person, there's some nuances you can't always see telehealth.
I wasn't going to share this, but since you brought it up, because when I'm thinking about, when I'm looking for a provider for mental health, I've been debating, does it need to be in person? Does it need to be on telehealth? And I feel if I do it on telehealth, because I spend so much of my life on this screen, I don't feel like I'll be able to disconnect. And I think I needed to disconnect for those sessions.
Yeah. And I will say it can be for some people, very helpful. I know everybody doesn't have the capacity or ability or availability to do this, but it can be very helpful sometimes to be in the space with that provider in person, because you're outside of let's say your work office, your home office, your whatever. Because when you're in your home office, you're still there. And like you just said, some of your mind is probably still there. But if you take yourself out of there into their office, you probably could, like you just said, disconnect fully in a way to be fully present with the person and with the process you guys are going to be going through.
And as a public person, I feel like if I go in person, the other people are going to see me. So it's so much going.
It's so much. I gotcha.
I know I'm not alone in that, and that's why I'm sharing it.
Yeah. Well, I see my therapist in person.
Oh, okay.
If it helps, and I'm very active on social media, but I see my therapist in person. Yeah,
it does help. Yeah, and I'll share that. Well, I don't know. I might not share that journey because I need something to myself, since I share so much other things. But I might say I've got someone. I'm in good hands. That'll probably be the extent of it.
Yeah.
And lastly, you want to give a plug to the Psychiatric Mental Health Nurse Practitioners Society of Color?
That was very close. You kind of mixed the words up a little bit, but that's all right. We still got the gist. It is the Society of Psychiatric Mental Health Nurse Practitioners of Color. This is a new nonprofit organization that I am a co-founder, and I have two amazing and wonderful, extraordinary, and absolutely intelligent co-founders, Dr. Letizia Baxter-Smith and Dr. Anya Attabong. We have come together to create this space for PMH&Ps of color, so that people have a space where they feel included in. People have a space where they can grow and let their needs and concerns be known, because we do know that health professionals of color can have some very specific types of experiences that not all other health professionals might experience or go through. And it can be very helpful to have someone to kind of talk through about that. But also, as a part of our mission, we want to make sure we are educating all healthcare providers about culturally inclusive and competent and safe care, because I am a Black provider and I love being a Black psychiatric mental health provider, but there is no way that me, this one person, can see all of the Black patients who are in Richmond, who are in Virginia, who are in the US. And so I need the help of all of the mental health professionals who work alongside me and within the US to make sure that they have this education about culturally inclusive care as well.
And so, yeah, people can come see you in Virginia. They can come see Ani in Maryland. And the other lady?
Dr. Letizia Baxter-Smith. She's in Tennessee, and I know she does do private practice. I don't know if she has openings or not, but yeah, she is in Tennessee.
Okay, wonderful.
Yeah.
Well, thank you so much again for coming on. We'll link all the resources you brought up today, as well as how to connect with you in the description box. Remember, everyone, you can email us your questions and show ideas at tmi.melanin@gmail.com. At the time of this recording, we release new videos weekly on Sundays at noon Eastern on YouTube, LinkedIn, Facebook, Instagram, and the audio at 5 a.m. on all your favorite podcast apps so that the night shifters can be the first to get something and not the last. And maybe someone will play it during Huddle and let us know about it. We thank you all for watching. We'll see you next time.